Good afternoon all. Sorry I was a bit delayed today because I was due to give my presentation a bit earlier, but there was an accident on the A12, so that was unavoidable. I'm all about understanding demand and challenging convention and doing it through applied research. I'm an alumni of this university and proud to be so, but I graduated back in 2000, so some while ago now. And my work is all about institutionalizing challenging convention and doing so through applied research, two of the central tenets of this university, which is why it stands out from the crowd. And like any good former student, I'm going to tell you what I'm going to do, I'm going to then tell you what I've done, and I'm going to just reiterate what I did by way of conclusion, okay? So I'm going to compare and contrast conventional thinking with what I call back-to-front thinking, which is a more intelligent way of thinking about how we run organisations and we approach performance improvement and change. And then I'm going to give you a few examples of where I've been working recently in the NHS, because boy, does that need to change and think differently about how it runs itself. And then I'm going to conclude with a few premises to leave you with. But first, I want you to just reflect on that. We all know him, don't we? I think he was right then. We've got a thinking problem in the way we think about how we design, manage, and improve organisations. And if he was around today, he'd be saying the same thing, I suspect. So what do I mean by conventional change? Well, conventional change for me is what I call back-to-front thinking. It's about having an obsession on removing costs by reducing activity and then telling students, customers, clients, service users, patients that you have to change your behaviour to fit in with it. I think that's completely wrong. I think we need to think completely differently behind understanding customer demand in its widest sense, which is not what we conventionally do. Conventional change is effectively summarised best as no research, no intelligence, no knowledge, no data. Leaders start with assumptions based on opinions, based on feel, and we see this in the public, private and voluntary sectors. They use things like aggregated data, which is useless, benchmarking, cost values to give them a perceived sense of what the problem is they have to solve. If you don't know this, you'll soon learn this in a few years' time, that actually change in many organisations then involves the litany of project management and governance reporting and documentation. You do things in endless amounts of detail around project plans, project initiation documents, business cases, risk assessments, activity metrics which bear no relationship to the outcome on the customer, the service user, or the client. Now, there's one big problem with that logic. It never works. Well, it does, but it results paradoxically in higher costs and poorer service. What I'm about is different. It's about front-to-back thinking, and front-to-back thinking is about understanding customer demand in its widest sense. Off the back of that, understanding the nature of the activity that the customer or the service user or the patient or the student presents with, and then achieving sustainable cost savings through the elimination of what I call activity waste. Now that's a grandiose term for saying every system, process, activity, procedure that adds no value to what the customer needs. Because front-to-back thinking, or a different way of thinking, is just about giving the person who is requiring a service what they need, no more, no less. That is often regarded and derided as gold plating. You know, you'll get it, but it will be at exorbitant expense. No, the gold plating actually happens when you continue not to do what the customer needs, because they disappear and then you lose revenue in the private sector or in the public sector. They keep reappearing, and you'll see that from the NHS. Now, I hope you like the slide. I think we've just had a general election. Health is the most complicated and complex service system there is. Now, in that general election, we heard loads of platitudes from all the parties, from all the political leaders, but we had no detail and no method and no real understanding. So we know we've got to find efficiencies. We know we want more money. We're going to have initiative-itis all over the place. We want doctors, nurses, GPs tomorrow, although we can't have them. I think what we've got to do is recognise over the last 30, 40 years, we've failed in everything we've tried to do in terms of changing and improving healthcare. We've standardised healthcare. We've over-commercialised healthcare. We've over-simplified healthcare. What we've actually got to do is humanise it, bring it back to why we have the NHS in the first place, which is actually understanding patients and give them what they need. I think that's of critical importance, and it's something we do too little of. We've also got to be prepared to challenge what I call two red herrings. I hope you like that slide as well, to illustrate the point. In that election campaign and before the election, you always constantly hear two things that are opinions. Remember, back to front. Rising public expectations on the NHS. You know, you, me, everyone, we're just demanding more and more of our GP or of our hospitals every year, year on year. There is no intelligent empirical evidence that actually collects any data of the kind. So that's just an untested, unvalidated assumption, opinion. Go and ask anyone who says rising public expectations are the principal problem and ask them where they got the evidence from, the research that backs that up. And then you'll hear them go silent. Second point, rising public demand for NHS services. You, me, everyone, we're using it too much. Naughty people, we must be told, we must change our behaviour. Well, I'm here today to show you some empirical examples to challenge convention that prove that that's absolute nonsense. But before I do that, it's important to understand healthcare demand, or any customer demand. So what do I mean by customer demand? Well, it's in the public sector, in any one year, the number of interactions that any one individual will have with a service or with an organisation. In the private sector, you would refer to it as transactions, okay? We do too little of this in conventional NHS. Conventional NHS land focuses on back-to-front thinking. It believes the following: that because of those two red herrings, people want more things and are using more things, we can't afford it, so we've got to manage demand. And that's a euphemism for rationalising through eligibility criteria and thresholding, keeping people away, saying the best service is no service. But my approach is to actually understand patient demand before you even attempt to manage any of it, because you're wasting your time otherwise. So I promised a number of empirical examples, and this is one of them. I'm going to look at secondary care first and we'll come on to a few others. But this is time series data looking at one of the largest acute hospitals in the country and by definition in Europe. It's looked at time series, so longitudinal, because the other obsession we have in the NHS and in service organisations is we look at it via 12 months or 4 quarters. But if there are any statisticians in the audience, you'll know that that is statistically illiterate, because it ignores the theory of variation. And you've got to understand variation to understand what's normal and what's not. So at the top is relative demand, expressed in percentage terms year on year over 5 years. At the bottom are absolute numbers. And what you see is challenging convention. In one of the largest hospitals that serves over 700,000 people in its locality, demand is stable and predictable in patient terms. Now that 33% boils down to 10% in A&E every 1 year, i.e. only 10% of the population use A&E, so it's not rising. 5% of the population use 50% of the resource. My argument is we better do a job of understanding the what, why, where, when and how of those 5% to redesign services and systems that meet their needs to reduce consumption overall and have appropriate care for them. Make sense? In absolute terms, demand is rising only in line with population growth. So it's stable, it's steady. That's what I call bad, but good. Because off the back of that, you can actually dig into the detail around the 33% and understand your customer base or your patients and understand actually, are we doing what we need to do to make you live a better life or give you dignity in death? Primary care. Now, the trajectory of demand in primary care is different because it's the front end of the NHS. So typically in any 1 year over time series data, you're getting 70-80% of people having need to use GP services, and it shows you there. But in this particular year, only 16% didn't access these GP practices, and I'm talking over 80 practices in the same locality. But demand is unevenly distributed, and that's important to understand. Again, the theory of variation. You've got 1% of this population, it's about 7,000 people, or less than 7,000 people, that are using 10% of the totality of the activity of these GP practices and 16% of the costs. We've also got 6% who are using a third of GP activity in any 1 year, and that's 41% of the costs. My argument is we've got to redesign systems and services around cohorts of patients. But in order to do that, we've got to understand who we're dealing with. And I'm afraid in the NHS, all too often we have a one-size-fits-all policy and procedure and operationals that does not address that need. Diabetes. Now, I talked about back to front and business cases. Now, this empirical data explicitly challenged what I call back to front business case, which stated categorically that there was rising demand for diabetes services in this particular hospital. When you actually took the time out to study the data, you realized that the rising demand wasn't a problem. What was actually happening was that the 60% of the total demand problem was the same numbers of people boomeranging back in year on year on year. Well, I call it representing demand, which means that if you've been into the acute with diabetes in year 1, the probability of you coming back in year 2, year 3, year 4 runs at 60%. New patients coming into the hospital with diabetic conditions were actually going down, not up. It's handy to know that. Now, I talked about activity metrics that are of no use to the organisation or the patient or the customer. And this is one of them. In hospital land, they obsess on reducing length of stay, individual spells that you spend in hospital. Now, over 5 years, you'll see on that first blue line going down that you might think they're doing the right thing, because individual length of stay is actually coming down. So you think that that sounds pretty good, tickety-boo, you're saving money. But remember, it's really small numbers of people who are boomeranging back in. So what they've failed to do is understand that. And as a consequence, the other line shows that when you use a better metric, a better measure, which is over 12 months, 24 months, 36 months, let's count up how many of those individual spells are responsible for one patient, or one patient was responsible for individual spells, you find that actually the costs are going up, because we might have squeezed on individual length of stay, but they're coming in more often. So we haven't solved any of their problem. I would hypothesize that they're getting bad care in the acute, which is why they're coming in all the time, and we haven't understood them to design what services and systems we need to be in place in the primary community sphere, which is what we need to do. But of course, what you've heard me say there is just quantitative analysis. And the part of applied research that you need to think about, and we do at Essex, is being able to combine the quantitative with the qualitative, the what and the why. And I want to talk about, for a few moments, the person I came into contact with a couple of years ago, who I labelled Mr. Eyelash Man, and hopefully this proves the point about what I'm trying to get at, which is front-to-back thinking is better than conventional change. He was a 50-something-year-old man who had a really minor, simple problem, which was ingrowing eyelashes in his right eye. Now, he'd been on various waiting lists for approaching 2 years. So the wheeze that the hospital had devised, and this happens all the time, it happens in A&E, it happens in elective procedure land, is, well, we have to meet our arbitrary targets, so we'll have you on this list 1 month, and then we'll disappear the next, and then you might emerge a couple of months later. And we'll manage our numbers that way, and we'll get ticks from Department of Health, from government, from Monitor, from CQC. We're doing a good job. But actually, when you pulled his file, it was nearly 2 years. What they told him to do in the meantime, whilst he was waiting for this simple operation, was to come back in into A&E, and this is what he did. And when you pulled the file and actually journey mapped him, you realised that you could predict almost to the day every month when he was coming back in. He would then spend, on average, 2.5 to 3.5 hours in A&E through the whole barrage and triage of A&E procedures. So we're telling him to come back in, but we're treating him like we've never seen him before, because he's going through the standardised processes, again, activity that's of no value, for a procedure that lasted less than 10 minutes. Now, when you mapped his journey and you cost accounted it, you soon worked out that actually it would have been cheaper and better for all concerned had we just operated on him in the first place. But because we're focused on not patients or people, but pathways, I do my bit in urgent care, planned care, primary care, the ambulance service, social care, acute, community, because we look at it from the perspective of service silos, and because we think vertically, those functions, not understand the patient journey and then think horizontally, how is he approaching these services and what value is there in the things we're doing, they were blind to all of that, and categorically blind. And as a consequence, costs go up, service goes down. What I also learned, which this was about a year before they introduced, I don't know if you're familiar with the friends and family test in accident emergency, was to ask someone what they thought of their experience when they're at the beginning or midway through a process, for example in A&E, is the wrong time to ask them. Because he said, I asked him, out of 10, what would you score your care? How was it, your experience, knowing that he'd been waiting 2 years? He gave it 9 out of 10 because the nurses were nice. Proves the point, doesn't it? That, again, anyone with a brain looking at this case could see that this was poor service, and it was costing us a fortune. So, back to front thinking abounds in the NHS, and it's the tribute factor of high costs. What we need to do is front to back. So back to front in healthcare in this country is really a focus on cost reduction for the reasons I've given, which leads to what I call, which is activity obsession disorder, trying to reduce activity in the belief that you'll reduce a few bob, but not taking the time out to understand how many Mr. and Mrs. Eyelash Man we have in our system at any one time, or indeed who are the 5% consuming over 50% of our resource. I think we should. Front to back thinking is understanding precisely that. Customer demand, patient demand. How much of the activity we do to these patients actually adds any value? Is it in the right setting? Should they be in a hospital bed in the first place? I can mention a hospital that I've visited and I've done some research in where 1% of the population who use that hospital, which is only 5,000 patients, are responsible for 80% of the total bed capacity of that hospital every year, a cost to that acute of over £50 million a year. They didn't know that. I think we should. Because if you do this type of work, and it is about changing mindsets and changing the way you think, if you understand customer demand and then design your service to meet just that demand, two things happen. Costs will drop and fall, quality as experienced by the patient goes up, but better than that, you actually create a learning organisation, because that's precisely what you're doing. You're learning to improve and you're improving to learn, because change can't be mandated in plans. It's organic, it's incremental. You learn by doing, you learn by making mistakes and then improving on it. So, to conclude, I think that as individuals, as society, as government, as leaders in the public-private sectors, as students, we have choices in terms of how we want to deliver services to citizens, students, customers, clients, service users, customers, patients, whatever label you want to give them. We can either put our head in the sand and say, everything you've told me today, Hamish, is just too difficult for me to get my head round, and I'm going to pretend you didn't say it. Or you could do the second thing, which is what I call fishbowl moments, or organisational Alzheimer's, which is, I don't believe you because you're rationalising me. So there I think that actually if I do back to front thinking or conventional change or improvement better, so I do my project management better and more thorough and more stronger, I'll get the desired result. Well, trust me, I've been in those environments and it doesn't work. It's the wrong thing righter. Or you can be prepared to think differently to achieve what I call the holy grail of service, be it in the private or the public sectors, be it in universities, in education, in local authorities, in retail environments, wherever, which is better service at less cost, which improves morale for the people that deliver those services and the recipients who receive them. So I'm going to conclude, lastly, by where I started this presentation, in saying that I think Einstein was right. If we want to affect positive change in any service environment, we've got to be prepared to change the way we think and act. Thank you very much for your time.